issues affecting public housing and welcome everybody to the current and emerging health issues affecting public housing and HUD-assisted residents. Today we're going to focus on addressing vaccine preventable diseases and immunizations. We're doing that because it's a major issue, and because of the time of the year, a lot of people are focused on flu and RSV and of course COVID, but there are a number of other preventable diseases out there affecting all age groups, from childhood diseases through vaccinations for adolescents like HPV, right up to vaccinations for adults or older adults like shingles and pneumonia. And this webinar is being brought to you in partnership between the U.S. Department of Housing and Urban Development and the National Center for Health and Public Housing. And I'd like to introduce Jody Moses from HUD to say a few words. Jody, go ahead.
Yes, thank you, Bob. Welcome, and thank you all for attending this HUD Strong Families event presented by and in partnership with the National Center for Health and Public Housing.
In progress.
HUD knows that health begins at home. Over the past 2 decades, housing has been increasingly identified as an important social determinant of health, to include fostering communities that understand the importance of vaccinations in attaining and sustaining good health. HUD also knows that it is only through each of you on this call, the professional practitioners, residents trust, and through your tireless work that this can be achieved. With over 55,000 babies born in HUD-assisted communities each year, and with over 40% of HUD-assisted households headed by seniors, the subject of vaccines for these two very vulnerable populations could not be more important. HUD takes our responsibility to facilitate federal collaborations in the health and housing arena, and realize that it is critical to appropriately respond to resident health needs. So again, thank you for attending today and supporting the health and well-being of the residents you serve. Thank you, and I'll turn it back to you, Bob.
All right, thank you, Jody. Okay, next slide, please. Okay, just real quick, we're going to go through introductions. This is the agenda for today. We'll do a quick PHPC overview of public housing primary care. Then we're going to have Dr. Melissa Briggs-Hagen from CDC. Melissa is also with the National Health Service Corps, and uniquely, in addition to her knowledge of infectious disease and vaccines, is also a doc at a community health center in Atlanta. Then we have Michelle Blanchfield, and Michelle is the VP for community engagement at Sioux Falls Health in New Jersey. And we're very pleased that Sioux Falls and their partner from Madison Housing Authority, Jessica Kirschenbauer, could be here today to talk about immunizations and vaccine preventable diseases and what they've done before, during, and after COVID, but also talk about the partnership between the health center and the public housing agency and how that works. And they're going to talk about, things that have worked well and the challenges that everybody faces, and a lot of them having to do with resources. And then we'll get into a Q&A and discussion and go forward with that. So now let's move on to introductions and housekeeping. So Fide? Okay. So just for housekeeping, all participants are muted upon entry. You can engage in chat, raise your hand if you'd like to unmute during a chat when we're actually opening up the mics during the Q&A session. The meeting is being recorded. Slides and the recording link will be sent via email to all. Next slide, please. And I'm Bob Burns, Director of the National Center for Health and Public Housing. And also moderating with me today is Fide Pineda-Sandoval, our Manager of Training and Technical Assistance. Fide is actually right in the middle of COVID right now, so she is graciously hosting or helping us host, but she will not be doing much talking. And then we'll also have our great partner, Jason Amerhaji from Neighborhood and Community Investment Strategy at HUD, who has been just a great partner over the years, and especially with respect to immunizations and vaccine preventable diseases. Next slide, please. And then our speakers again, Dr. Melissa Briggs-Hagan, Michelle Blanchfield, and Jessica Kirschenbauer. And we are pleased now to turn it over to our first speaker, Dr. Melissa Briggs-Hagan. Melissa, go ahead, and maybe you could also mention what health center you're with in Atlanta.
Sure. So great to meet everybody. I'm Melissa Hagan. I volunteer at the Good Samaritan Health Center in downtown Atlanta, and I'm an internal medicine and pediatrics physician by training, though I do.
Okay, Melissa, just hang on. If you can hang on 1 second, I realize I just need to do a quick couple of slides on relative to PHPC,
Sure.
public housing, primary care. So next slide, please. Okay, as you may or may not know, there are about 1,363 federally qualified health centers serving about 31.2 million people nationally. 475 of those FQHCs are near and serve public housing residents, serving about 6.5 million patients in those health centers. And 107 of those 175 are public housing primary care grantees, where they receive funding to provide services to residents in public and assisted housing. And they serve about 992,000 patients. Next slide, please. Public housing health center patient demographics in general, very, below the federal poverty level, about 60% female, about 30% children, 11% elderly, and about 19% uninsured still. Next slide, please. And in terms of public housing resident demographics, not the patient demographics, but public housing residents, we're talking about in public housing, traditional public housing, 1.6 million residents, around 2 persons per household, 32% female headed with children households, 40% Black, non-Hispanic, 29% white, 26% Hispanic, about 35% have children, 40% have an elderly resident, about 23% have a disabled person in the household, and about 90% very low income. Next slide, please. All right, so at this point, I'm going to turn it over to you, Melissa, so please go ahead.
All right. So good afternoon. I'm excited to be talking to you all today about vaccine preventable diseases, why they still matter, and how you can help. I agree that this is a timely topic, and I hope this will be useful to you. I also look forward to hearing from you all about what we at CDC can do more to help in your efforts. And I do want to start just by saying thank you for all the work that you are doing on behalf of public housing and HUD assisted residents. It's a very valuable and important space to be working in. Next slide. So I'm going to start by talking about VPDs through the ages, both in terms of what vaccines are recommended for different age groups, but also providing a quick historic snapshot of some vaccine preventable diseases in the US. Next slide. So we'll run through the first set of slides here pretty quickly, but this is just an overview. Hopefully many of you have seen this chart before. This is CDC's updated vaccine recommendations for children from birth to age 6 and represents our core routine childhood vaccines. Next slide. And what you can see is the RSV antibody has been added to this. So this is the monoclonal antibody given to infants under 8 months who were born during respiratory virus season if their mom did not get the maternal RSV vaccine. Next slide. And the other vaccine should be pretty familiar. So we have our routine vaccines given at ages 2, 4, and 6 months, many of them in combination forms. Next slide, we have our annual, seasonal, and respiratory virus vaccines, COVID-19 and influenza. Next slide, and we have our early childhood vaccines needed prior to starting kindergarten, the measles, mumps, rubella, and chickenpox vaccines. Next slide. So all told, these vaccines protect against 16 illnesses that cause a wide array of serious childhood diseases, as well as a number of infections that can have complications well into adulthood. Because we don't see many of these infections anymore, I did want to take a step back and just give a little bit of an overview of a few of them that we may have learned about, but maybe don't remember as well because, again, we don't see them as often now due to vaccination. Next slide. So the first one I picked to highlight was diphtheria. It's an interesting and deadly toxin-forming bacteria. The symptoms of infection are typically sore throat, difficulty swallowing, and if severe, neck swelling. The feature diphtheria is most known for is that it would form a grayish plaque or pseudomembrane in the throat that when severe or inadvertently dislodged could obstruct an infected person's airway. And I remember, at least in my medical training, having this fear of using a tongue depressor in somebody with diphtheria and the possibility that that could that could kill them, which is something I ended up never seeing. Before treatment was available, almost half of people who had diphtheria died, and even with treatment, it had a death rate of 5 to 10%, so highly fatal. Thankfully, this is now very rare in the US. Rates dropped dramatically after vaccines were scaled up in the 1940s, though this does remain endemic in some other parts of the world. Next slide. Tetanus is another toxin-producing bacteria that was both deadly and common prior to vaccines. It is from a bacteria that is present in contaminated soil and is typically introduced to the body through a puncture wound. The toxin that it produces affects the nerves, causing muscle spasms, violent contractions, often starting with stiffness of the neck and jaw, which gave it the term lockjaw. And the graph at the bottom shows that tetanus cases as well dropped quickly after vaccination was introduced in the 1940s. Cases do still occur sporadically. Most of those cases are among people who are under vaccinated. And even with treatment, the death rate among those who are infected is very high. Next slide. I wouldn't want to do an overview of VPDs without touching on poliovirus. Unlike the organisms I just described, polio is caused by a virus, and the initial symptoms can be quite mild, including no symptoms or just a flu-like illness. Complications of polio include meningitis or infection of the fluid around the brain, and what it's probably most known for, paralysis. Although less than 1% of people who are infected with polio would be paralyzed, large outbreaks are common, such that at its peak, over 20,000 cases of paralytic polio were reported in 1952 alone. Again, following the introduction of vaccines, cases dropped off dramatically, and the last case of wild-type polio in the US was reported in 1979. Though you may recall that what's called non-wild-type poliovirus was detected in an unvaccinated person with acute paralysis in New York just a couple of years ago, and was also detected in wastewater. So it is still circulating. It is also still not completely eliminated from other parts of the globe. And so, maintaining vaccination rates is quite important. Polio is also quite interesting in terms of the fact that lots of famous people had it. I mean, I always tend to think of Wilma Rudolph's story. Found out this week that Mitch McConnell had it. So again, this is, I think, part of our national history in terms of vaccine preventable diseases. Next slide. Lastly, and most significantly, I'll just touch base quickly on measles, which of the ones I mentioned is the one you're most likely to have seen. It's an acute febrile rash caused by the measles virus, transmitted by direct contact with infectious droplets, or also spread by airborne route. It is highly contagious. 90% of those who are susceptible in a household with measles will develop illness if exposed to a measles case. And this means this term R naught here, it's the number of people a single case can infect. It's estimated to be 12 to 16 in an unvaccinated population. So it spreads like wildfire. Measles is really one of the main reasons why we need very high vaccination rates to keep outbreaks from occurring, with that target being 95% coverage. I'd be interested to hear, since we have the chat box open, if any of you have seen a measles case or been involved in a measles outbreak. Would love to hear about that in the chat as we go through this. Next slide. The most common measles complications are diarrhea, ear infections, pneumonia, but 1 in 5 cases do present with more severe complications, usually dehydration or pneumonia, and may be hospitalized. Encephalitis, which is an inflammation of the brain, can occur in 1 in 1,000 cases, and death occurs in 1 to 3 of 1,000 cases as well. So I think a lot of people think of measles as a generally mild childhood illness, but of course we do have these severe complications, especially when large outbreaks occur. Next slide. So just touching on vaccines for older children, there are fewer of them. The main ones that are added are HPV, the Tdap vaccine, the meningitis vaccine, and again, you see here the seasonal flu and COVID-19 vaccines. Next slide. And so the ones that are most specific for this age group are HPV and meningitis, both of which caused a lot of illness and even death among young adults. And HPV specifically is a common virus that causes cancer later in life. About 13 million people, including teens, become infected with HPV every year. Next slide. HPV infections and cervical precancers or abnormalities detected through a pap smear, for instance, have dropped since 2006 dramatically, as that's when HPV vaccines were first introduced in the US. Among teen girls, infections with HPV types that tend to cause cancer or genital warts have dropped 88%. And among vaccinated women, the percentage of cervical precancers caused by HPV types, the types of HPV that cause cervical cancers has dropped by 40%. So this is substantial. Again, not just in the acute space, but in the chronic disease space as well. Meningitis has also dropped substantially, but I will have a slide on that a little further down. Next slide. The adult vaccine schedule looks large, but most of the ones in light blue are really just for targeted populations who either didn't get vaccinated in childhood or have specific high-risk conditions. The routine adult vaccines, as shown in dark blue, are really the seasonal vaccines, again, COVID-19 and influenza, which we know can cause severe disease in older adults and those with underlying conditions. The newly approved RSV vaccine with similar indications, and then the Tdap every 10 years or with pregnancy. The more historic and maybe longer term known adult vaccines include the 2-dose shingles vaccine for people aged 50 and above, and the pneumococcal vaccine, which prevents multiple types of pneumonia in those over 50 years of age. Next slide. And this slide just provides a little more detail on those core illnesses that these vaccines address, available for you as a resource later. Next slide. So I'll now move to briefly highlighting where we are in terms of vaccine uptake, focusing primarily on children and adolescent vaccines because that's where we have the most data. Next slide. This graph, which is available on CDC's VaxView, which is if you type in CDC VaxView, you'll see there's web pages for kind of all of our different vaccines that we monitor, and you can choose state, region, year, vaccine, and really see kind of where we are on uptake. This is all done through a national immunization survey, which we do every year through random calling to determine kind of vaccination rates. So this graph shows the uptake of the core early childhood vaccines from 2017 until 2023. At the bottom, it's the birth year. So because these are people born in 2015, and we're looking at their vaccination rate by the time they're 24 months of age, for instance, it's really kind of representing vaccination in 2017. But what you can see here, next slide, is that coverage of the measles, mumps, and rubella vaccines declined from 92.3% in 2020 to 90.1% in 2022, but it's since then stabilized and even increased slightly to 90.6% in 2023. So slight decline, not complete recovery since the pandemic. Next slide. Unfortunately, being up to date on all core vaccines is a bit lower, having declined from around 70% in 2021 to now around 66% in 2023, which leaves a lot of young toddlers, again, vulnerable to many of those infections I was describing. Next slide. Among kindergartners, we assess coverage by school year. Next slide. And shown here, the MMR, or measles, mumps, and rubella coverage actually reached our target of 95% in the 2016 to 2017 school year and remained at 95% or higher all the way up until 2019 and 2020. Next slide. It then declined during the pandemic, especially for children living in rural areas or below the poverty threshold, many of whom I believe are children that you serve. It initially stabilized at 93%, but appears to now be dropping a little bit further with coverage rates of just 92.7% during the last school year. Next slide. As shown here, so I just presented the graph on the left, as shown on the right, these trends have been accompanied by a steady increase in exemptions, especially non-medical exemptions. So at the bottom in green are medical exemptions, which has stayed stable, and purple is the non-medical exemptions, and in blue are the total. And this scale here is just going up to 3%, so it's not that exemptions are extremely high, but they're high enough for it to be interfering with the coverage that we need. Next slide. And there's also substantial variation across states. So 10 states now, as shown on the right, have exemption rates that are over 5.5%, meaning it's not even possible for them to achieve the 95% coverage needed to prevent outbreaks of some of these very infectious agents. Next slide. And unfortunately, even such small declines do have a big impact. This slide just shows that small declines in vaccine coverage in Europe led to a 30-fold rise in measles cases there, prompting the CDC to issue guidelines on vaccinating children as young as 6 months prior to travel. Next slide. And then we've also, of course, seen a number of outbreaks here. In this current year, we've seen more measles cases than the last couple of years combined, and have tracked and had to, of course, respond to a number of outbreaks. Next slide. Adolescent vaccines are a bit newer, so the trend looks slightly different in that we're really seeing great increases in coverage from the early 2000s right up to the pandemic. And then what we see is that those increases stalled somewhat over the past few years. And according to the National Immunization Survey, meningitis conjugate vaccine coverage was 88.4% among teens aged 13 to 17, and HPV coverage was 78.5% among females and 75.1% among males aged 13 to 17. So plenty of room for growth, though I think, you know, the history here is quite good. We've seen substantial improvements right up to this most recent period. Next slide. This slide just highlights that some of our most vulnerable populations are most adversely affected by low uptake. So the yellow-orange bar in these two graphs represent uninsured patients. The blue bar represents Medicaid patients, and the purple represents privately insured. And as you can see, vaccine coverage is generally highest for privately insured patients, with the exception of HPV, where Medicaid patients actually have higher coverage. Go Medicaid, HPV vaccine people. Uninsured patients have the lowest vaccine coverage for all recommended vaccines, however. Next slide. Okay, so I want this, even though we have this kind of concerning data and drop-offs that we are very, interested in addressing, I do want this to be an encouraging talk today, because overall these vaccines are amazingly successful interventions, and I think there's still a lot of work we can do to make a big difference. Next slide. So first, just to note, this is the 30-year anniversary of the Vaccines for Children, or VFC program. And since its inception, the VFC program is estimated to have prevented over 470 million illnesses, over 1 million deaths, and saved over $2 trillion. So for all of you who are working, accessing, distributing vaccines for the VFC program, take pride in these numbers. It is an enormous achievement. Next slide. And then, of course, as I was mentioning at the top, this has had a huge impact on a wide range of illnesses. This graph shows the road to measles elimination. So the US still qualifies for measles elimination at this stage. And that was really driven by the introduction of the vaccine first in the 1960s, and then further strengthened by the introduction of the Vaccines for Children program, which was really launched after some lessons learned when we started to see a resurgence of measles in the early 90s. Late 80s to early 90s. And this has drastically increased availability of routine and recommended vaccines for un- and underinsured children in the US. Next slide. We'll just go through these next couple of slides pretty quickly. We basically see similar things when we look at chickenpox or varicella, which I think most people think of as a mild illness, but again, caused quite a number of hospitalizations and deaths pre-vaccination, all of which dropped off dramatically once 2-dose vaccines were introduced. Next slide. And then I mentioned meningitis earlier. So meningitis disease incidence in the US declined dramatically between 1996 and 2019. We've seen some slight increases in 2022 and 2023, which we're watching closely, and something our vaccine policy folks are continuing to reassess. Next slide. And lastly, we can see declines in pertussis. Here, this shows declines from 1922 to 2023. We still do see some intermittent peaks of pertussis outbreaks, never as large as what it looked like prior to vaccines. But this is something, again, you may continue to see in your practice, and maintaining vaccination for this is quite important. Next slide. So I'll touch on a couple of resources. In terms of resources, the CDC has developed a number of toolkits that are available to different stakeholders to try to increase awareness about vaccines. The Let's Rise initiative was really aimed at increasing rates of routine childhood vaccinations following some of the declines we saw during the pandemic. And it was really an interagency initiative that has been super helpful for mobilizing different resources in this area. Both the Department of Education and HUD have been key partners in these efforts. And our Let's Rise lead asked that I give a specific shout out to Red Mitchell and Jason Amarati for their work with CDC to amplify vaccine messages through the HUD Strong Families newsletter. So thank you both for those efforts. Next slide. This slide has links to a number of resources, including some in Spanish, for those who are interested in further serving as vaccine champions. And again, please access them. Please let us know what you think about them. If there's something missing or something that would be helpful, we're always happy to work on those things. Next slide. We also have a number of communication materials that we make available to anyone who's interested in further sharing messages about vaccines. So this one on the left, I think I mentioned on our last call, this is the Keeps It That Way campaign. And it really is saying that a lot of these illnesses aren't recognizable because vaccines have been successful and vaccines keep it that way. So this says he thinks diphtheria is the name of a dinosaur. Childhood vaccination keeps it that way, for example. And so these are materials that have been developed and are available online with CDC if you would like to print or distribute any of these. And on the backside of these, there's actually more information about the illness and the vaccine to be able to educate populations with. And on the right, the maternal vaccine tools from Me to You are really targeted about improving vaccination coverage for pregnant people, especially people of color who have the lowest vaccination rates during pregnancy. And the goal is to really give an empowering message that vaccines provide protection for infants, and it's a way of transferring from Me to You that protection. All right, last couple of slides. This next slide shows our respiratory virus season tools and resources. So a lot of these have been updated this year based on feedback we got from stakeholders like yourselves to try to make things simpler, more accessible. So on the left, you see the respiratory illness data channel where you can go and type in your county and find out what's happening in your area. And right now you can see this is our latest snapshot as of December 13th. Respiratory illness has gone up to moderate. The last time I presented it was at mild. And so you can track those things closely and by virus with some of these resources. And on the right, we have our fall and winter immunization guide and our respiratory virus guidance snapshot in terms of other ways to protect yourself during this season. And this is my last data slide. So next slide shows some promising findings. It's not exactly where we want to be, but we can see in pink and purple are COVID-19 vaccination rates from this year as compared to last year in orange and blue. And for all age groups, especially those over 65, it's higher. So kudos if you've been working in the COVID-19 vaccination space. These are improvements that we just need to continue to build on. All right, so last slide. In summary, vaccines save lives, but only when they're accessible, successfully offered or requested, and ultimately administered and received. And opportunities to further improve uptake of vaccines exist, including further expansion of VFC, improving insurance among young children, sustained attention to maintain the gains that we've already achieved, and continued partnerships like these across sectors to combat misinformation and disseminate useful information through trusted messengers. Next slide. This is just, again, a thank you. Your efforts to help patients make well-informed decisions about how to protect themselves and their families does make a difference. So thank you.
Thank you.
All right, Melissa, thank you very much.
Yes.
Really appreciate it. And that was kind of a great, I guess, macro overview of what's going on with respect to vaccine preventable diseases and vaccines, and a number of great resources there that I think we can all use. And next up, we've kind of heard a lot about vaccine preventable diseases, and now we're going to talk to a couple of folks who have actually been working it, on the health center side and the public housing agency side. And so we're going to begin with Michelle Blanchfield from Sioux Falls Health in New Jersey. And she's going to talk about what they've been doing relative to vaccine preventable diseases and what they've been doing with their great partners at Madison Housing Authority. So Michelle, take it away.
Good afternoon, everyone. Thank you, Bob. Yes, my name is Michelle Blanchfield, VP of Community Engagement for Sioux Falls Health Center. Fida, do you have my slides or do you want me to share?
I believe I do have your slides. Let me, these are, yes.
Okay, great.
Yep.
So, like I said, I'll tell you a little bit about our partnership with one of our housing sites here in New Jersey. But first, some background on Sioux Falls. So we are an FQHC. We've been serving Northern New Jersey for the past 35 years. We are unique in New Jersey in terms of our special populations because we are one of the only health centers serving residents of public housing, people experiencing homelessness, and migrant seasonal farm workers, aside from the general public. So we do have those 3 special pops that we focus on in my department and with my community health workers outreach staff. This current year that we're in 2024, we've surpassed the 50,000 mark in terms of number of unduplicated patients served. We do have a really strong outreach team. I'm so grateful. I think some of my team members are on this webinar right now, and I'm so grateful for the work that they do every day to engage and identify individuals and families who not only need vaccines, but need a health home, need primary care, and link them to care at Sioux Falls. We provide medical, dental, behavioral health, and enabling services. And here's a picture of our founder, Dr. Zufall, who passed away last year. He was shy of 100 years old, and up until he passed away, was still very active on our board. Next slide, please. So our approach to working with housing sites is essentially we throw out a very wide net in terms of engaging, right? We reach out, again, we cover 7 counties. We reach out to multiple housing sites to let them know that we're here to serve their residents. We inform them about what services we have to provide, what special programs we have to offer. We let them know that we have our mobile units. We both have a mobile medical unit and a mobile dental unit that can come out and provide services. And we really try to build trust with the residents at the various housing sites that we visit. And we use an interpersonal approach. Zufall, our clinicians, our staff are trained on trauma-informed care. And so that really is sort of meeting people where they're at. There's an image here of some of my staff members at a vaccine clinic that took place in Phillipsburg, New Jersey, about a year ago. And then here I have a graph on, according to the counties that we're in, the number of residents in public housing served. We've been in Morris County, New Jersey, the longest, and therefore we have the highest number of residents in public housing that are served. I also want to maybe give you an overview really about in general. Obviously, Zufall, we encourage all age-dependent vaccines. A lot of the conversation that's going to happen today between Jessica from Madison Housing Authority and myself was around our COVID and flu vaccine clinics, because since there were standing orders for flu and COVID vaccines, it made those clinics easier to convene for community pop-ups because there weren't any providers that were required. So we've held dozens of clinics to provide COVID and flu shots, and prior to that, testing events for COVID across Northwest New Jersey since the start of the pandemic. We also have held things called Peds in the Park or Pediatrics in the Park, which are events where we partner with schools, Head Starts, local health departments to vaccinate children for their, if you will, their catch-up vaccines, the MMR, polio, in order to ensure that they can stay in school. And Zufall uses an integrated practice to ensure that to assess our patient's vaccine status and determine at different types of visits if a vaccine is needed. For example, we can have a pediatric patient that has a dental appointment, but we identify that patient is in need of their HPV vaccine, for instance, right? And so that vaccine could be administered in the dental chair during that visit. Okay. Sorry, let's see. So next slide, please, Vida. Some promising practices in terms of working with the public housing sites. Number one, communication is key, right? Ask yourself, if you're a health center or health center representative sitting in this webinar, right? Ask yourself, how are you communicating with your target audience, with the residents of public housing, with the managers, with the social service agents at that housing site? Are you keeping in touch with each other, right? So communicating is key, and having collaborations with other community-based organizations within your service area to bring services that the residents need or information that they can value is definitely a plus. Plan ahead and in between. I know for us, we're planning our 2025 calendar already, and we have a number of events where we're visiting either, again, with our mobile dental or mobile medical unit, or we're just going in to present around our services, or we might have a class that we've scheduled a location for. And oftentimes the feedback I get from a lot of the various housing sites is that the residents there can really value not just the health information that we can offer, but going in with a little bit of a softer approach, like going in with a holiday craft idea, right? And having the seniors or the family members or the kids tangibly work on something easy and fun. And if you can engage health information like the importance of your HPV vaccine for children during a session like that, it can be an easy way to start the conversation. Next slide, please. There are obviously some challenges, right? Number one, resources are limited. So first off, the staffing, right? If you have an outreach team, if you're a health center that has an outreach team, or you have someone who's engaging with that housing site, you want to keep those lines of communication open. And if your outreach representative, if there's turnover in that role, right, it can be hard. It can be a barrier to engaging with with those housing sites if there's continuous turnover in one of your organizations. So again, having like a team of individuals that can stay in touch is helpful. In terms of supplies, the supply of 317 vaccines for anyone over the age of 19 years or older is extremely limited. And so that can also put a damper on how much we can do outside of our clinical settings. Obviously, time, because anytime you're hosting an event, a clinic, a vaccine pop-up, or any type of event, it takes time and time is limited. And so there's a lot of coordination, a lot of communication that goes into that, a lot of planning. In order for our vaccine events to be really successful, we have to make sure that all of the registration paperwork is completed. If you're dealing with individuals that are below the age of 19, especially children, obviously, and for different types of vaccines, you want to make sure that you have their vaccine record. And if you don't, that can hinder the process. Obviously, misinformation on vaccines is still prevalent, especially in some of the more vulnerable populations that we engage with. And so making sure that you can share with the residents of public housing information and resources on where they can get accurate information that's easy for them to understand in a language that they can understand is really important. And then obviously there are competing priorities, right? So depending on where your health center is in terms of resources available, this is a conversation you want to have with your housing partners, right? In terms of what's feasible right now and what's not. It can be possible to bring a provider out to a housing site in order to administer vaccines. However, sometimes there are limits on the type of vaccine, like the vaccine requires that it's administered in a clinical setting or in a pharmacy, for instance. Also, depending on the insurance type, that might also, depending on the insurance of the patient, that might also dictate what limits you can administer the vaccine, how you can administer that vaccine. Also, if a resident in the housing site isn't an established patient of the health center already, it can be a barrier because they would have to change their PCP on their insurance card. Otherwise, your health center may not get reimbursed or you can't bill for that vaccination. And so there are definitely some challenges, but with that said, it can happen. It's just a matter of how much time and energy both parties have on either end to invest in this event that you want to have. Next slide, please. Some of the techniques and resources that we use are offering the residents evidence-based programs. So for instance, one of the things that we offer our seniors in the housing sites is a matter of balance class. It's an evidence-based program. It's a series of 8 classes that happens around fall prevention, right? So again, you could start off with something like that, and that'll help you form a relationship with some of the residents in there and build trust, and then open that conversation to, hey, what vaccines are you missing? Are you engaging with your primary care provider? How often are you visiting them? Are you making sure that you're getting all of the medical screenings that you need? And therefore, it's more likely that they trust you and you can set an appointment for them and they can get the vaccines that they need. Motivational interviewing has also been shown to help improve our vaccination rates in terms of assessing someone's readiness to become vaccinated, meeting them where they are so that we're really listening, showing empathy around any concerns or fears they might have, and then continuing that conversation because you have a physical presence and you're engaging with these residents at regular intervals. Again, talking about using the trauma-informed care approach. Obviously, sometimes residents are going to have other needs than just medical, so addressing other social determinants of health, for instance, transportation barriers that someone might have. Maybe they want to come to your health center to get vaccinated. Maybe you don't have a mobile unit that can go out to them. So you're thinking about who else in your area, what other organizations can meet the transportation need, and possibly what we've done in our health center is block out schedules for a number of appointments for residents in housing, and then get them transported to our sites in order for them to have that visit and get the vaccines that they need. Everyone on my team is fully bilingual in English and Spanish. We have language lines available if there are residents in a housing site that speak a language other than English or Spanish. Oftentimes we'll also use volunteer residents themselves. We've worked with housing sites where it's Mandarin is the predominant language spoken, and none of my team members speak Mandarin. So ensuring that you have someone from the housing site that can help with some of the translation is also effective. Next slide. Okay. Again, that's it for my slides, and Jessica's up next. Thank you so much.
Hi, everyone. Good afternoon. Really happy to be here to talk more about our relationship with Zufall Health Center. So I'm Jessica Kirchenbauer. I am currently the rental assistance manager for Madison, but my story with Madison started back in 2012. I was actually hired as a Ross coordinator through a contract as with a nonprofit partner for the Madison Housing Authority. And in that role, I started to build relationships with partners in the community to bring resources to our residents here in Madison, one of which was Zufall Health Center was one of my first contacts. So Michelle and I have known each other since 2012. And even through all the different transitions, we've maintained contact to kind of assist with that. So Madison is in northern New Jersey. We're part of Morris County. It's a pretty affluent area here. There are a lot of services in Morris County, which we're very appreciative of. But I have to say our partnership with our local FQHC with Zufall is one of our biggest partnerships. They really have a lot of services that our residents here need. The fact that they have mobile units with medical and dental, that's really where the relationship started with their dental van, that they could see people who have Medicaid as an insurance option, Medicare as well. And then for people that were uninsured, they have an affordable sliding fee schedule. So all of our residents could be seen, which has been fantastic. I have to say, we've had that going for, it's gonna be 12 plus years. Madison itself, the borough of Madison actually created the housing authority. It was really the residents here in Madison that wanted affordable housing for their residents here, which is, it's very expensive here in Madison. So it's really interesting that it was the borough itself that really felt it was important to have a housing authority when it was created back in 1970. It wasn't some kind of federal mandate. The residents wanted the housing authority here. We're a very small housing authority. We have 56 units of family affordable housing, 80 units of senior affordable housing, which is now, was public housing, and we were one of the first ones to convert to RAD, rental assistance demonstration, with project-based vouchers back in 2015. And we also have 194 Section 8 vouchers, housing choice vouchers, HCBs. Next slide, please. All right, so like I said, Michelle and I built this relationship back in 2012 when we had a Ross grant. That was the first year that we received it. But in our conversion to RAD in 2015, unfortunately, we were no longer eligible for that grant, as we were no longer considered public housing. Since then, now, we've been ineligible for that grant. And in the last go around, now that RAD converted, public housing authorities are now eligible to try to get that grant. We are trying our hardest to get a Ross coordinator back on staff to really provide those linkages, service coordination, and social service coordination. So the Ross is a HUD grant for a resident opportunity and self-sufficiency funding to hire a service coordinator to assist public housing residents or RAD residents. Now that's been converted, it does not assist Section 8 residents in social service coordination. So, if somebody has a goal that they want to achieve or need help with certain things, so they'll provide linkages to perhaps benefits in the community. If they need help with a food stamp application, they need help applying for Medicaid, health insurance for their family. Maybe assistance with utility assistance, anything like that. It really does provide more of a hand-holding situation to get residents what they need to be successful. We've seen the benefits of that over the years. So, for me, I came on as the Ross coordinator. Once we lost that grant, I transitioned into the family self-sufficiency coordinator for the agency. So I maintained those relationships with all of our partners, including Zufall. And really, I was the one who was, helping create those events. It does take a lot of time, getting the information out there to your residents, and building those relationships. Being on site, to help kind of coordinate it that way they saw familiar faces. It is very helpful to have staff to really be involved and invested in those relationships. I have more of a social service background is where I kind of came from. I have a master's in clinical counseling, so I've always considered myself a social worker, even though my role here at the Madison Housing Authority has evolved over the years. So I feel it's very important, for people's success to really have all the resources available as much as possible. In moving through the transition, eventually I came on staff as the office administrator back in 2019. I still maintained the relationship with some of those social service agencies, including Zufall. But for our housing authority, which is very small, we only have full-time administrative staff here. So it does make it a little bit difficult without having a social worker on staff. I really would recommend housing authorities, if they have an FSS grant or a Ross grant, or they try to get a grant, or maybe there's some other extra funding to get, maybe an on-site social worker to really help residents become successful and really make those linkages. I really do find it to be extremely helpful in the overall success of the residents. But, our relationship with Zufall too, I know we're going to talk a bit more about the vaccines later, really started with the mobile dental van, but they also had a whole bunch of other things that they offered. We had multiple SNAP Ed classes. So that was an education class with nutrition. SNAP is, the new name for food stamps. So we had someone coming every week with our seniors to teach them how to make healthy meals and talk about nutrition. And they always really, the senior population is one of the easiest populations to really work with, because we have a large senior building with a community room and our seniors are looking for things to do. So that's always the easiest starting point with any social service agency, is to really start working with your seniors. It's a little bit harder with families with their schedules with work and school, but it'd be great if we were able to get a little more things going on with that. Always the dental van was always open to everybody. But we also had other things like Live Your Better Life senior wellness classes that someone came every week to do mindful thoughts and, talk about health and challenges. We had a couple of different nurse education events where a nurse would come from Zufall to test blood sugar, talk about medication management, all other kinds of topics that were important. And they even at a point had AmeriCorps volunteers, and they started their own intergenerational program they called ZIP, which brought a young person to work with our seniors. They did all kinds of things with, chair-based yoga, making ornaments, just hanging out together, doing, YouTube fitness classes together, which they really enjoyed. And having that relationship prior with a lot of our residents knowing who Zufall was, really made it so much easier by the time, we're talking about those vaccination clinics. So moving on to that next slide. So our main concern back when COVID, was a pandemic, things were absolutely horrible for our residents. We immediately restricted access to our senior building on the onset of the pandemic back in March 2020, and we enforced a very strict safety protocol for our residents and just their essential caregivers with access to the building. It was a very sad, very hard time. All the activities stopped. We had our, community room locked down to kind of limit interactions, just to try to limit the spread and keep everybody healthy. And our main goal and top priority was to get, vaccines to them as soon as possible, which at the time was very daunting. I don't know if you guys remember, but at least in New Jersey, it was very difficult to get an appointment to be vaccinated. There was an online scheduling. There were sites maybe by county where they had a bigger vaccination site, very difficult to get an appointment. If you were able to get one, maybe it was out of county. How were my seniors going to get there? It was very, very, very challenging. So, Sioux Fall, when we found out they could come on site with vaccinations, I mean, the world changed. It was amazing. It was such a happy day. So they actually came on site to provide the first vaccination for our seniors in January of 2021, and then came back a couple weeks later as scheduled for the second dose in February. And we are so appreciative of our relationship with Sioux Fall to make that happen for our seniors and our disabled population. And honestly, we had no known coronavirus cases among those residents during the pandemic due to, our safety protocols and having the vaccines available through Sioux Fall for our residents. Next slide, please. It actually was such a big deal when it happened that we actually had our local Congresswoman, Mikey Sherrill, come. Sioux Fall's president and CEO, Ava, came, and so did our mayor to actually witness this event of vaccinations for our seniors. So it was really something, exciting and joyful and normalizing at the time. Since then, Sioux Fall has been there to come back for every, booster shot that's been needed to provide vaccinations on site, also with flu clinics, either doing one or both, or whatever our attendants needed at the time, which has been super helpful because our residents are always asking us, when are they coming back? When is the next one available? When can I get my next shot? So having the ability to have them come is really a big deal. And I know in talking to Michelle, if there were options of other vaccines available to come on site, RSV, pneumonia, I'm sure our residents would be very interested. And as I always say, my relationship with our partners, I'm kind of a taker. If you have it and I think our residents would benefit, I want it. We have the population of people that, is a special population that people want to help, and we're more than happy to bring those services to our tenants if they want them and we think it's beneficial. So we super appreciate our relationship with Sioux Fall over the years, and expect it to continue for many more years, even if I'm not the one directly coordinating those events anymore, but I'm still involved because it's important to me.
Well, Jessica, thanks for that. That was outstanding. It's great to hear what you guys have been doing together. There are a lot of questions in the chat. And Fide, are you able to get Emily mic'd up so she can go ahead and ask her questions?
Yep. Hi, Emily. I have unmuted your line. Okay, so hopefully she'll be able to ask the question at some point. We also had another participant that had his hand raised, but I don't see him anymore. And then we also have another question in the chat. And it says, FQHC here, what is the best way to promote, educate on the importance of vaccines to special patient populations with cultural differences from a marketing strategy and marketing outreach perspective?
Michelle, could you take that?
Sure. So what we find is really effective is having our clinicians engage with patients directly, right? Like making sure that the providers are having that conversation during an exam visit, whether it's vaccines, different types of screenings. Patients will take the information more seriously if it comes from a clinical provider. With that said, obviously, it's hard to have if your providers aren't in the exam rooms seeing patients, then you're not generating revenue, right? So it's hard to get the providers out into the community. In which case, what we've done is specifically to housing sites, we've tailored presentations through our community health workers, through our outreach team members that clinicians have created. And we have like interdepartmental meetings where we talk about the content and then have the community health workers deliver that content to the residents of a housing site during those educational sessions that we've mentioned. I mean, that's one way to get it to out in the community, right? Other than that, think about what channels of communication your health center is using, whether it's different social media platforms, looking at the materials that you have inside of your exam rooms, in your patient waiting areas. I don't try to reinvent the wheel. A lot of like what Melissa showed that the CDC, you have access to those resources. I would definitely use those. And also taking advantage, sort of like riding the wave on anything else, right? What can you link a specific vaccine to? So during Cervical Cancer Awareness Month, right? If you have a partner that's doing some kind of cancer education prevention session, right? That's a good place to link information around HPV, for instance, right? So you ask, hey, can I join you? Because I have like a 5 or 3 minute spiel on HPV and how it relates to cervical cancer, right? That could be important for the audience to hear. So think about, again, those communication channels and your presence. And when you think about your presence, your online presence as well.
That makes sense. And Jessica, you indicated that that your residents are very receptive, to different health initiatives that you put forth. I mean, how do you get them interested? Is it events? Is it promotional materials? Is it social media? I mean, how does that work for you guys?
So at least in terms of our seniors, we always make sure we let our seniors know what's going on. We have a bulletin board where we post flyers. We do a monthly calendar with events, and then we individually send individual flyers into all their mailboxes. If we don't hear from them, we'll give them a call to say like, hey, this thing's going on. Like you said, you were interested before, do you want to come? Honestly, they're a very captive audience. They like things to do. So when you add that social aspect into it, plus adding in the health stuff, it really tends to work a lot. Like we've run different classes with Matter of Balance and Project Healthy Bones. There are other classes like Take Control of Your Health that focus on diabetes or cancer or pain management. And they always tend to do better with things that, they're involved in moving and then just not listening to something. So sometimes just the educational piece is very boring, but if you could pair it with bingo, or you could pair it with an arts and craft, or you could pair it with like some kind of exercise thing, you'll definitely get more people. Oh, of course, snacks. Let me let you know, you always want to feed them. So something nutritious, something that they could do together. Always have food. Just try not to make it so sugary.
Food always helps.
Food always helps. You'll get more people if you give them something. And they
And-
like
and we're-
swag,
we're
and
getting a
you
little
have
tight
fun.
on time, so I'm just going to ask Dr. Hagan, Melissa, just in your practice in your health center, what I guess are you guys focusing on in terms of trying to continue the progress that's been made with respect to immunizations and vaccinations, over the last 50 years really. So how do you make that train keep moving in the right direction?
Yeah, I mean, so I serve primarily in the clinician role there as opposed to kind of an advisor role. I know that they do have a collaboration with our local public housing department and that we do vaccine, clinics and outreach, through the clinic as well. We have, flu shot days, people can come in, those types of things when it's seasonal vaccines. And then we do have, I think the way the clinic is set up, it's also, it tries to be a one-stop shop. So we have dental services, we've got medical services, we've got nutrition services. So having kind of different reasons that people are motivated to come to the clinic, I think help, at least with the patients that I see. And then for me as a clinician, it's just those kind of continued conversations. We generally have good uptake of the routine child vaccines and even RSV. I've found that we haven't had a lot of pushback with the giving nirsevimab, and COVID is still a challenge, flu is still a challenge, but the rest of the vaccines we tend to have pretty good uptake. But I think, yeah, it's kind of those continued conversations right now from my standpoint as a clinician, and understanding what people's concerns and fears are, and making sure to give them adequate information.
Well, thank you so much. Well, thanks,
Yeah.
Dr. Melissa Briggs-Hagen, Michelle Blanchfield, and Jessica Kirschenbauer for your time and the great information. The slides from today's session will be available. I'm thinking maybe the next session we do, and we're going to be doing at least 3 more sessions over the course of the coming year, I think in maybe January, February, March, April, May timeframe. So keep an eye out for notice for that. But maybe we need to add a few minutes onto our session if people can make the time to join us. And we ask that you please complete the evaluations, because it helps us understand what works and what doesn't work, and what you guys need for information going forward. And Fide, is there anything else we need to cover?
Yeah, so just very quickly, I know that we're right at the hour. And then we have some additional questions that were just submitted in the chat. I would like to hopefully follow up with you on your questions, but I will be doing that via email. That way, you can have responses to that. And in addition to that, just make sure that you also go on our website to access our latest publications, webinars, and other activities that we have been hosting. And we have a few upcoming trainings in the month of January and February, which is here. Everything is going to be provided in the slides. And this is our contact information. And this is it, Bob. I don't have anything else.
All right. Thanks very much for being with us. Thanks to the speakers, and happy holidays to everyone. Take care.
Bye.
Thank you.